Dr. Suketu?
Yes, sir.
Yeah, we can move on to the next test.
Yeah, our next speaker is Dr. Dhruv. He is a young retinal surgeon working at Dr. Gadre's Eye Care Center. He is doing very nice retinal work, and today we would like to see his case, what is to present. Over to you, Dhruv.
And thank you, Suketu bhai. Thank you, Purval sir and team ROS for giving me this opportunity again. I hope the screen is visible. I'm audible.
Yes,
Yeah.
yes.
So I'm sharing a case or a surgical video of one of the surgeries, which is not something new, but rarely do I dare to attempt such cases. This is a young 8-year-old boy who came to our OPD with complaints of decrease in vision in the left eye. They were unsure regarding the duration of onset. When accidentally the father was playing with the child, they closed one eye and they noticed that the child was not seeing. So the other eye, I'm sorry, I don't have a picture since the child was not cooperative. So the eye, the seeing eye, that was the right eye, the anterior segment was normal. And the child had a refraction of about minus 9 diopters sphere and multiple rows of lattices. The other eye had a total retinal detachment with advanced PVR and a mildly subluxated lens with some amount of cataract, and the vision was PL plus in the affected eye. So seeing the advanced grade of retinal detachment, they were already advised against surgery. The same thing I did when I first counseled them, but they were insistent that they wanted to try. So under the risk of abandonment of surgery and the risk of phthisis and need of multiple surgeries, they were insistent to try something, and we proceeded with the surgery. So starting the video for the same. So you can see the rim of the subluxated cataract. We decided to do a lensectomy. So proceeding with the 26 gauge lensectomy, decided to remove the whole lens and the capsule since the subluxated support might not be good enough to place a secondary IOL in the future. And this is just a small snippet showing removing of the equatorial part and the lens capsule 360 degrees. The fundus, sorry, I again did inferior PI, planning silicone oil tamponade in the post-op period so as to prevent any inverse pupillary block, and then proceeded with the vitreoretinal component of the surgery. Yeah, so as you can see, this is a highly advanced PVR and the periphery is full bare choroid with some tessellations that are seen. This cabbage-like or rosebud-like thing is just the amount of retina that's left. So I decided to proceed with the surgery, cut that stalk of vitreous that was there, inserted a chandelier light in a 25 gauge sclerotomy port inferiorly, since a bimanual approach will be required. I decided to just follow the vitreous stalk hand on hand so as to try to reach the disc. This is me trying to search any subretinal membranes that are there, since this would be the best time to remove them. I had 360-degree access to them, but unfortunately they were just retinal convolutions. There were no obvious subretinal membranes. Now, with the light pipe in one hand and the forceps in the other, I'm just trying to tease out the immature membranes and the condensed vitreous that is there, hoping to go more posteriorly, trying to open the funnel and reach the disc. I shifted to a bimanual approach, used forceps in both the hands, trying to tease away the membranes, trying to open that rosebud. So gradually, the anterior funnel was opened. Some semblance of a disc was just seen, teasing out membranes further. You can see the funnel is starting to open gradually. Change the forceps. This is a SFIOL forceps that we use since it gives a better grip to the membranes. And gradually, once the funnel was opened a bit, I decided to inject PFCL so as to make the posterior retina a bit more stable while working anteriorly. Then with the injection of and removal of membranes, gradually this retina opened up, and now we are able to see the disc and this yellowish spot that is the macula. Now at least I was sure that I would not have to abandon the surgery and some amount of retina could be salvaged. The upper reflection is just a small dewdrop like BSS on the biome. Sorry for that. Yeah. So this large bit of membrane or condensed vitreous was removed with the cutter, and I proceeded further with the surgery. The next part was these transverse membranes that were holding up, preventing in a purse string form, preventing the retina from opening further. So I decided to just sort of loosen the purse string by stretching the fibrosed part of the retina there. This was done about 270 degrees, since the nasal convolutions that you note are much more. The temporal part is a bit more open. So gradually even the anterior purse string started to open. And furthermore, it was again repeated nasally, inferonasally, and superonasally. Yeah. On further injection of the PFCL, now starting to open, or as of instead of a giant retinal tear, what as of now looked was like a giant retinal dialysis that had occurred, but it did not change my plan of action in any way as of now. This was the last bit of membrane, which with the help of PFCL, the posterior retina was tamponaded, and it helped me in removing this large bit of membrane in toto. And now on further injection, the inferior part, as you see, is still standing up, in spite of PFCL suggesting that there is some intrinsic retinal contraction that's happening inferiorly, and retinectomy would have to be done inferiorly. So I proceeded with the cautery marking inferiorly. This one has to just take care not to injure the choroid in this phase. So being a little generous with the relaxing retinotomy here, since I removed the PFCL, lifted up the inferior retina, and then proceeded with the inferior retinectomy. Completion of this minimal inferior retinectomy, now for the PFCL was injected, and one notices the settling of the lifted part inferiorly. Most of the surgery was now over. Just I barraged the 360-degree edges of the retina, and then PFCL was exchanged with silicone oil. Yeah. So this was the look on completion of the laser under PFCL. 360-degree, about 5 to 6 rows of laser, and then oil. There was a direct PFCL silicone oil exchange that was done. So post-op, the child was doing well till the 10th day follow-up that I had seen. The retina was attached in the same way as what it's looking now. On the follow-up, after on about the 20th day, there was again curling of the inferior and the nasal edges, and gradually this was about 1.5 months prior this surgery was done, and the child did need a repeat surgery for a recurrent RD, which was done today, in fact. The problem was that the child was not positioning. They were positioning prone at least only about 1 to 1.5 hours a day, in spite of repeated efforts by the parents. So they were keen for the to try something for vision. The vision was counting fingers 1 meter at that point. This is just a small two snippet showing the surgery today, the pre-op. This is the starting of the surgery today, showing the lifting up of the nasal and inferior retina. The temporal edge seemed attached. And just at the end of surgery, I would like to show a small snippet. Just 2 seconds. This was at the end of surgery. Again, today I had to do some radial retinectomies here, but was able to reattach the full part. So all these cases are just dire approaches to save whatever minimum amount of vision we can. Explaining them that this eye would always be the weaker eye, and God forbid if something happens to the other eye, the child might have minimum ambulatory vision, and that is the. Thank you. I end my case here.
Thank you, Dr. Dhruv. Excellent surgery and excellent recording. We could see all the folds and the cauliflower retina first, the mulberry appearance, and then later on opening up, blooming up beautifully. Well done. Of course, these surgeries always have this problem of intrinsic fibrosis and redetachments and the curling up of the edges, as you said. Yes. But that doesn't stop us from trying out, because a fair number then remain attached and maintaining useful vision.
Yes.
Now, how much was the cataract initially to start with?
The cataract was, the amount of cataract was a little less, more of cortical and a very minimal posterior cortical, but the lens was inferiorly subluxated.
Okay, so that needed the lensectomy.
Yes, sir.
Because if we can preserve the lens,
the capsule,
then sometimes the prognosis is a wee bit better. Yes. Of course, it depends on the fibrosis, and I think the patient presented early enough so that the fibrosis intrinsically was not that much, but it required a lot of patient dissection. I saw that you did it beautifully, right? And did you use 5,000 centistoke oil or?
In the second surgery, I did, sir. First was just the 1,500 centistoke.
And how much of the inferior retina got redetached after that month or whatever?
It was about 10 to 20% inferiorly. More, it was nasal fold which was coming over the disc. Surprisingly, it was a little surprised because the inferior one was what was more contracted. But right. Maybe the retinectomy helped in the first surgery.
Right. Sometimes you can work under the silicone oil without removing.
Yeah, I tried that, sir, but it was the nasal one was not lifting. It was a bit stiff there, so I had to remove it and do it.
And that procedure in the second surgery of the radial cuts,
yes,
probably in these cases of 360-degree giant tears or dialysis, probably has to be employed in the first surgery itself, so that it gives a bit of leeway for yes. the contraction to be stopped at some point.
Yes.
Yeah, I'd like others to pitch in with their comments, please. And just for the benefit of others, let me tell you these chandelier-assisted vitrectomies under oil and these 360-degree giant tears and all that requires enormous patience and very good surgical view. It requires enormous patience and continuous working on their skills, and Dr. Dhruv has demonstrated that very nicely in these videos today.
Okay, sir.
So if there are no more questions on this case,